Thank you. Good afternoon. I want to thank Adam and Harry for the invitation, and thank you for your attention today. I'm happy to talk about real-world data with Bulevirtide, and the caveat here, of course, is these are not Gilead-sponsored studies, but one would hope that the data generated in the real world would align with the studies that are being done for registration. These are my disclosures. So what I'd like to do today is briefly review the current approval status for Bulevirtide, and then, because of the time limit, really focus on some representative real-world studies and give sort of a top-level overview of the data and how these compare with ongoing clinical trials with Bulevirtide. And of course, we need to point out along the way the strengths and limitations of this sort of comparison. We all know that Bulevirtide is a first-in-class entry inhibitor for treatment of chronic Delta virus infection. Specifically, it's a linear polypeptide that is chemically synthesized. It binds to NTCP directly and thereby blocks entry of hepatitis D virus and also hepatitis B virus into hepatocytes. In July of 2020, Bulevirtide was approved as Hepcludex by the European Medicines Agency for the treatment of chronic HDV infection. This was a conditional approval, which was based on data from two small phase 2 studies, MIR 202 and MIR 203. The agency in Europe knew at the time that there were additional studies ongoing, a phase 3 study, MIR 301, and a phase 2b study focused on finite treatment, MIR 204. And those studies are still ongoing, we'll read out shortly. This is the indication and posology in the SMPC in Europe. It's indicated for the chronic treatment of chronic hepatitis delta virus infection in serum or plasma positive HDV RNA positive patients with compensated liver disease. I should point out Bulevirtide must be given by subcutaneous injection. The dose is 2 milligrams given once daily, and it's indicated to be given as monotherapy or in combination with nuke analogs for treatment of underlying HBV infection. So the label is silent on use in combination with interferon. And then lastly, the optimal treatment duration is unknown, and treatment should be continued as long as it's associated with a clinical benefit. Sort of a nebulous statement, but we can't argue that that is true. It's just the specifics around that are difficult to know. So what I'd like to focus on today is the use of Bulevirtide for chronic suppressive treatment at the 2 milligram dose level. In his background, the MIR 202 study looked at ascending doses of Bulevirtide at 2, 5, and 10 milligrams compared to a control of TDF, and all groups received also concomitant TDF for underlying HBV infection. And in this study, the endpoint at 24 weeks, the on-treatment endpoint, evaluated virologic response, which is a standard definition, more or less, of 2 log decline in HDV RNA level or undetectable HDV RNA level. Also, secondary endpoints in the study were ALT normalization and the so-called combined response, which is ALT normalization and the virologic response. And you can see the results here. Virologic response was achieved in over 50% of participants, and there was no clear dose effect seen. The combined response also was similar between the treatment groups, and ALT normalization was seen early in week 24 in about half of the patients in the study. And after discontinuing 24 weeks of treatment, rebound occurred in nearly all patients. I should also point out this data is now published in the Lancet Infectious Disease Journal with Heiner Wiedemeyer as the lead author on that. Now, really the gold standard for chronic treatment is our MIR 301 study, a phase 3 study, where patients are randomized 1:1:1 to either 2 milligrams or 10 milligrams of Bulevirtide compared to delayed treatment. The primary endpoint results at week 48 were presented at EASL this year by Heiner Wiedemeyer, marvelously, I might add. And in this analysis, we also did a pre-specified alpha-controlled week 24 analysis, which was presented earlier. The study will continue treatment through 3 years, or week 144, followed by an off-treatment period. So using this as a backdrop, I think we can look now at some of the real-world data. And to put that in context, these are the results that were presented for MIR 301. The primary endpoint, combined response, was achieved by similar proportions in the 2 and 10 milligram group, and similarly, a higher proportion achieved virologic response, and over half achieved ALT normalization at week 48. So these data do support the label for 2 milligrams once a day by sub-Q injection, and have been submitted to EMA and are currently under review, but not yet in the European label. I should point out also that not unexpectedly, because of its mechanism of action, elevated serum bile acids are seen with bulevirtide treatment, as we can see here from the 301 study. These are dose dependent, they occur early, and the mean levels are relatively stable over the treatment period. Would also like to point out at baseline that in all treatment groups, the bile acid levels were above the upper limit of normal, which is 10 micromole per liter, and those levels remained at or above the upper limit of normal in the control group through 48 weeks. Now, if you really want to dig deep into the data, I would recommend this recent publication, and it's not because Pietro is sitting here in front of us, but this is really an excellent review recently published in Journal of Hepatology, looking at the clinical data to date for bulevirtide given alone or in combination with pegylated interferon, and also includes a very nice overview of all of the real-world data to date. And I will also point you to the fact that at ASLD coming up, there are a number of cohorts that will have updated data that will be presented, some of which, including Pietro's Italian cohort, will be part of the late breaker presentation on Tuesday morning. So looking at the 24-week data collectively across some of the major cohorts in Europe, the light blue is the 24-week data from the MIR 301 study. For reference, you can see we've broken it down by virologic response, ALT normalization, the combined response, and also in this analysis we included undetectable to show that it doesn't occur very often at 24 weeks. And the cohorts included are the Italian cohort, the French cohort, which is one of the largest cohorts that's ongoing, and the German cohort. So at 24 weeks, the data appear, again, with the caveat of not doing cross-study, all the limitations of cross-study comparisons, that the data are generally consistent across cohorts compared to the controlled trial. And I think this is important because most of these patients in these ongoing cohorts had an urgent need for bulevirtides. They tend to be more advanced in their disease, the majority of which have compensated cirrhosis and advanced fibrosis. Moving to week 48 responses, these are the data comparing the cohorts in Italy, France, actually 2 French cohorts that have been ongoing, as well as a German cohort, comparing those 2 results at week 48 in MIR 301, again in the light blue on the far left. And the takeaway message here is that these cohorts through 48 weeks seem to be generating similar response rates to what we see in the controlled study. And that's, I think, important information to take to heart. Just to move on now, I don't know how much time I have left, a minute left, just a couple of examples of this. This is the French cohort that will be updated at this year's ASLD meeting, but this cohort looks at a group of patients receiving bulevirtide alone and those receiving it with pegylated interferon, which is not a randomized analysis, but rather the physician preference. And you can see the characteristics of the group here with a very high baseline viral load in this population. And looking at their response rates over this 12-month period of time by a per protocol analysis, you can see in the dark blue, green that the response rates for the combined response are generally comparable to what we saw in the 301 study with very good safety and tolerability. And then lastly, I will mention the Italian cohort. This is published in These are patients with advanced cirrhosis and clinically significant portal hypertension. It's a cohort of 18 well-characterized patients, and the response rates are really quite remarkable. And this paper is really worth looking at, and I think an update of this was also presented at Delta Cure, if I'm not mistaken. So very exciting and very important data coming from these cohorts. So these are my conclusions. I think it's pretty clear that the need for these cohorts remains, and we look forward to seeing longer-term data as we also will be generating longer-term data with Bulevirtide in the ongoing program. Thank you very much.